Thank you to Chris and Lori. And I should say, just a quick editorial, I hope Chris is right and that gravity is taking us a good direction on stigma-free environments. I am more skeptical, and I think it's going to take a lot more work, but that's why we have this great panel of experts to sort some of this out. Dan Gillison is the CEO of the National Alliance on Mental Illness, the nation's largest grassroots mental health organization. Dan, it's great having you here. Courtney Hunter is Vice President of State Policy at Shatterproof, and we just heard a bit of Shatterproof, where she works to engage policymakers to eliminate barriers to addiction treatment. Dr. David Fiellin is the director of the Yale School of Medicine's program in addiction medicine. The program works to improve and expand access to prevention and treatment services and substance abuse. And Jim Carroll, whom I mentioned just a short while ago, is the former director of the Office of National Drug Control Policy. Welcome to all of you. Thank you. Well, Dan, let me just start with you for a minute and help maybe set the stage. You wrote an op-ed for us, and thank you for that, in The Hill, that looked at, where you were advocating that we needed to have, it's called 988 Crisis Response, a promise in peril, and kind of looking at how we need to reimagine our response to this crisis, which we've been discussing today. Can you give us the highlights of that, and can you help us open the door on what the most important priorities are in dealing with him? I mean, we have got Jim on, and under his tenure, we had a drop in at least opioid-related deaths. I know the picture is much bigger that we're talking about, but there's just no way around the fact that the pandemic's been horrible for America, and mental health challenges are perhaps higher than we've seen in generations. So, what's your recommendation of what we need to focus on?
Yeah, thank you, Steve, and good afternoon or good midday to everyone. In terms of the focus, and you brought it up, you raised and teed it up perfectly from the standpoint of 988. If you look at where we are, this is an inflection point. The demand for mental health services was tremendous before COVID, and the supply of resources was limited. So that demand has gone up as we've been living in isolation and have seen some of the things that have occurred in terms of the COVID. So 988, what is 988? To realize 988, first of all, it's a transformative opportunity for us from the standpoint of right now we have 911. If there is a person in a mental health crisis, the number that a family member calls is 911. Oftentimes you get the wrong type of response. You get a law enforcement response when you want a mental health response. And neither organization or neither area wants that. So the 988 number will provide the following. It will provide a 3-digit number for either national. It is going to replace the 10-digit National Suicide Prevention number. So it will replace that. And it's also going to be for a mental health crisis response. So a member in a community, if they have a loved one that's having a mental health crisis, the number that will be called is 988. The realization is that, or the opportunity for the realization is that when you call that number, you'll get a mental health response. Now, that is something that we see that will go operational in July of 2022. When we say operational, there's a lot of work that has to happen for that to actually be realized, meaning that on the front end, we don't have enough resources to actually stand it up. And on the back end, after you pick someone up that's in a mental health crisis, where do you take them? So we have to build out on the back end, and we have to build the talent on the front end to actually provide those resources. Steve, I'll just leave you with this quick thought. I don't live too far from a substation. They've got about 30 cars. For every 30 police patrol cars, for every 5, wouldn't it be wonderful to have one mobile crisis unit that is staffed with a triage team of a behavioral health expert, a peer specialist, and to be able to go out on that call and to pick that person up safely and to take them somewhere where they can get the care that they could absolutely benefit from. So that's what 988 is for us. And the need is for us to really realize that it's going to take all of us talking about it and marshaling the resources to make it a reality.
Dan, thank you for setting the stage for us. Dr. David Fiellin, you're a man of science and a man of scientific practice. And I'm just interested in what science tells us that we most need. As you look at this, we've been having, I think, a really great set of conversations today with really, really well-meaning people. And I guess one of these people where I love earnest folks who want to make the world better, but I'm wondering if there's a bank shot in this, if there's some unexpected dimension that could help actually help us strategically jump into a much better situation? Or am I naive? Is this all going to be incremental, step-by-step process? What does science tell us?
Thank you, Steve, and I appreciate the Hill for your attention to this and the Hartford for sponsoring this work. I'm actually a primary care physician. I do have a specialty in addiction medicine, and at some level, I see primary care as the de facto mental health and substance use disorder treatment system that we have at this point. And so if we can provide resources to the frontline providers in primary care, invest in workforce education, and quite frankly, I think science has told us what we need to do, and we have effective interventions. The limitation is implementation of those effective interventions at the frontline resource. And quite frankly, I think we would go a far way to address stigma by addressing it more directly where patients feel comfortable: primary care, hospital, OBGYN clinic, pediatricians' offices. Those offices need support. The providers need education, but those offices need support. And so, if anything, science has advanced to the point where we have effective interventions. It's now on us to implement them with haste.
Before I jump to Courtney and to my friend Jim, David, I just want to ask you another question. I want you to grade the literacy of Americans in the aggregate on how they deal with folks suffering from mental health. I would give them a very low grade. I want it to be higher, but I'm a realist. I want to know, National Council of Behavioral Health has tried to do mental health first aid and spread that around the country. I know that Dan Gillison is working so hard with the National Alliance on Mental Illness, but it just seems to me whenever I see a case out there in real life, I see everybody I thought would be humane and empathetic and sorted out run the other way, and I'm just wondering, what do we have to do to turn that around so we not only get empathy at that moment, but we get kindness and we get, the right sorts of interactions to help that person in need and crisis?
Yeah, Steve, that's a great point. I think for a long time, traditionally, we viewed mental health and substance use disorders as weaknesses of the will and moral failings. And the science of addiction and the science of mental health has really exposed the extent to which there are not only genetic, environmental, but basically neurobiologic changes that explain the behaviors that we see. And in the same way that we've demystified areas in cardiac disease, in cancer, I think we need to be able to demystify these issues in patients who have mental health and substance use disorders. Because what you said at the outset of this program, that we all have this in our family, we all know somebody who's impacted by this, and we all know those people to be good people, and they just have a condition that needs to be recognized and treated appropriately.
Well, thank you for that. Courtney, you just got, Shatterproof just got mentioned by Chris Swift. I guess I'd like to know how you folks work. We're talking a little bit about workplace stigma. That means that folks in the workplace are aware that there are some people with these challenges, and you've kind of helped put together a toolbox, a toolkit, a pathway, a patterned set of responses that help employers help their people manage this and to create healthy workplaces. So how do you do what you're doing? Without giving away your trade secrets.
They're not trade secrets at all, Steve. And thank you so much for including Shatterproof in this event. And thank you to the Hartford. We know that in the last year during the pandemic, fatal drug overdoses have increased by 30%. That is drastic, and it should be a call to action for everyone in this country. At Shatterproof, we are dedicated to reversing the addiction crisis. We're a national nonprofit that's focused on increasing the quality in addiction treatment, reducing those barriers to addiction treatment, educating families and loved ones so they know where to turn when this hits home. And really eradicating stigma, as this has kind of been the topic so far, during this conversation. And it is pervasive. It prevents most people from getting treatment. It exists in our, our families, and we don't really want to know somebody or work with someone, right, who's struggling with addiction, and that has to change. And I will also mention that as we have this conversation about mental health, so often mental health and addiction are, comorbid. They live together, and we need to be treating them together and not in silos, and really bringing them into the medical mainstream and looking at behavioral health disorders and not just addiction and mental health. But these are disorders of the brain. And as Dr. Fiellin, pointed out, we need to be arming our medical providers and practitioners with the right tools to screen. Because right now, not everyone wants to screen because they don't know where to send their patients. They're not equipped with the resources and the data and the time to help folks. And that's really, as he mentioned, the frontline providers are key in that. And at Shatterproof, on the policy side, we're working a lot to integrate behavioral health services into the primary care setting through something called the collaborative care model. And making sure that our Medicaid agencies are covering that and understand the importance of that within primary care, particularly as so many folks have lost their jobs this year and have gone on Medicaid. Medicaid is of utmost importance as well, in addition to private insurance. So I say all of that to say there's no secret sauce. There's no silver bullet to solving this crisis. These problems and barriers to treatment existed before the pandemic, and they were exacerbated by the pandemic. And so we need to double down on what we know, what works, but we also need to be innovative. We need new research, but we also need urgency. And so I'm just so grateful for all of us working together on this. And we know that this is a treatable illness, and that people do recover. And I think that's really important as we see all of these headlines around, the fatal overdose numbers, that people understand that you're not alone. There's treatment available, and treatment works. And we have, 23 million Americans that are living in recovery every day. So I'll leave you with that.
No, I mean, I think it's very powerful what you said. And look, I mean, the Hill in my time here in the last couple of years has made this topic a priority. This is not the first one. We've kind of come around many times. And, Senator Debbie Stabenow, I talked to a few weeks ago, has done a lot with Roy Blunt and others to sort of elevate the questions of broad mental illness, resources. But one of the big questions, I'm going to throw this all to Jim Carroll in a minute, but there's an economics of this too, where you look at hospital centers, you look at states. Part of it is money, and we kind of think, well, there's going to be money provided, but it's getting. What does wellness mean if mental health is not built into a health system, or if it is and it's just the orphan child on the the left? So there are a lot of alignment issues when it comes to how do you get gravity moving in the right direction so it reinforces support of that person who is having challenges. So Jim, I mean, I want to come to you, and if you heard John Katko earlier, he cares about this issue deeply. David Hayes, Senator Stabenow, others across party lines, and people credit your work with helping to get a decrease in those that had died from opioid addiction, trying to make a dent in this, and then the pandemic hit. And I would just like to say to you, so first of all, thanks for that. And what are the key pieces of this puzzle that would help us understand from a policy perspective what we need to wrestle with?
Well, first off, Steve, thank you so much for having me on. But more importantly, thank you for continuing to push this message. All of us are experts. All of us understand the issue, but you give us a voice. And therefore, the key policymakers, the key lawmakers that are participating and watch your show, watch the Hill, are able to really be influenced by it. And that's what's critical. And Courtney just said it. Right now, time is of the essence. And there are going to be some scientific breakthroughs. I do believe that. But I also think while we do that, we also need to take advantage of some of the technology that is out there and push for some of those changes to happen as well. And we're talking about reaching some of the most vulnerable people. That starts really at a very young age. And we have to be able to recognize that the year that so many kids missed from school has really had a detrimental impact on not only their mental health, but also on the messaging they get, the prevention education they get from folks like Shatterproof, from SAD, and from others, where they learn the techniques from their peers to be able to say, no, I don't want to try this or try that. And so that has been important. But also, as we look back over the last 15 or 16 months of the pandemic, we estimate that 100,000 people died of a fatal overdose. Those are just horrific numbers. And we need to stand up and make a voice, just like you're doing, Steve, for those people who so desperately need it. And that is the purpose of having this, to make sure that people understand that stigma is real and we have to fight it. And it really, not only does it need to take place at the workplace, but it starts at home. And it starts to recognize that our family members are the ones that we can see closest, usually, and that they're the ones that we can get hope and help to the most.
Let me just ask you all, and go to Dan, Jim, Courtney. One of the things that struck me as I was preparing for today that I just didn't know is when Congressman Katko talked about, for every person who unfortunately succeeds at suicide, there are 29 other attempts. If you look at the Trevor Project and young LGBT youth, 40% in this last year ideated or thought about suicide. And of course, I understand there are workplace stresses and other issues. And what does a workplace mean anymore in a COVID area where you're not in touch with everybody in the workplace, but you're online or you're at home or whatever? I'm just, interested, Dan, do you have any kind of thoughts on how we navigate that? What do we do with young people who I guess don't have the support and hope about their future wherever they may be? It just really struck me today preparing for this, and just wondering what you and your members and the folks you work with are advising, parents, friends, teachers, folks out there with contact with young people, because that number is huge.
It is huge, Steve. And one of the things that we experienced last year is we have a helpline. And that helpline, we saw our numbers go up by 65%. And many times those were parents calling, looking for resources, looking for ideas. So one of the things that we try to do is connect them with resources. And what our young people really want is they're looking for, you mentioned empathy. So it starts, you mentioned empathy at the very beginning of this. So that's one of the things they're looking for. And the other thing that really was compromised last year was hope. All of our young people are looking for that hope. Then we can get into the science of the solutions. But from just the practical standpoint, our young people are trying to navigate something that all of us have never experienced, which is this isolation and a different kind of environment that is uncertain and has all of this doubt. So we begin with trying to provide resources through our helpline. And what we recognize is that when we talk to parents, what's so interesting is the two things that we see when we speak to parents that's the common denominators are fear and lack of hope. And that's what we try to bring back to them by sharing with them some resources that they can access that can help them. And we also have programs that we provide for schools and for educators that are touching the young people. So we're trying to do a number of things, but that's where it starts for us from the standpoint of really speaking to the young people as well as the parents.
Thank you. Courtney, can I get a quick answer from you? Then I'm going to take a question from the audience for our other guests, but jump in, Courtney.
I'm not good at quick answers, but I will try. That was really stunning what Dan just shared in terms of, hope and lack of hope and fear being very pervasive. And I think that goes hand in hand with stigma. What we need to do to eradicate stigma is to tell stories. And to connect people with resources so that those stories aren't being told in isolation, but that when somebody has a moment of desperation, the tools are there. So as Dan mentioned, the helpline, the 988 number, critically important. But also we need to make sure that on the addiction treatment side, when someone is ready to go to treatment, that they're not being preyed upon because they're going to Google and typing in detox near me or rehab near me. And they're thinking that for themselves or for a loved one, most often for a child, that your child needs inpatient 30-day treatment. And that might not be the case. So at Shatterproof, we're working on quality metrics through our Atlas program and connecting treatment providers and patients with quality treatment and trying to bring those standards up to the medical mainstream. So critically important. And then all of the educational efforts that the Hartford is doing by connecting employees to actual resources through our Just 5 program.
Well, thank you. We have an audience question from Keith Renshaw. Keith?
My name's Keith Renshaw. I'm a licensed clinical psychologist and a professor and chair of the psychology department here at George Mason University, just outside DC in Fairfax, Virginia. My question is this: are you aware of any existing or planned scalable models of stepped mental health care with easy entry points that are embedded into widely accessible prevention work to help reduce stigma and increase accessibility, possibly in combination with follow-up stepped care that could better address the broad needs?
Let me go to David Fiellin and then Jim Carroll. David?
That's a wonderful question. And, stepped care is the idea that you start with perhaps a low barrier and a low intense level of treatment. And based on the patient's response, you increase the intensity of the services and the medications and counseling that the patient receives, because not everybody needs the same level of treatment. There's no sort of cookie cutter that everybody requires an intense level. And so to the question, there are emerging programs that are starting to integrate medication initiation, for instance, buprenorphine, in prevention programs, so syringe service programs. We have a program in New London, Connecticut, where we partner with a syringe service program and we initiate treatment and we provide a linkage for that patient to get into formal addiction treatment at an opioid treatment program. And so we do need to investigate low barrier programs, quote unquote, meeting patients where they are, and then increase the intensity of services based on what the patient is interested in and based on their clinical response, the way we do in all other medical conditions.
Thank you for that. Jim Carroll, I'm interested both in your answer to his question, but also, do we need to do something? One of the things come up with regards to opioids is that we don't have the infrastructure in place so that first responders and others that need to provide, Narcan or others, that infrastructure is not there. Is that right or wrong? Jim?
Well, first off, in terms of the stepped care, we certainly have seen some cities where they have a central hub, a central place where people are brought when they're suffering from either a mental health illness or in conjunction with an addiction illness. And thereby going to a central hub, the idea is that they then can put them in a facility or get them the treatment that is most appropriate, but also immediately available. And so these hub and spoke type models, I do think, are the future for a lot of facilities and for a lot of communities so that they can get care, especially to some of our communities that have been historically underserved. In terms of our first responders, there's a lot of law enforcement groups that are desperately trying to understand addiction. They already understand that incarceration is the last thing that is helpful. It does not do a single bit of good. And so one of the things that a lot of the law enforcement are doing now, in particular, the International Association of Chiefs of Police, is working with communities, local law enforcement, and teaching them de-escalation techniques for free, for dealing with people who are in the midst of an overdose or in the midst of a mental health issue. And so they're teaching them de-escalation techniques, but also they are carrying naloxone. And thankfully, more and more people have naloxone. I carry it. Everyone should learn how to use it and have that on them. And there's also more powerful versions of naloxone coming out, really to address fentanyl overdoses, which are the leading cause of these fatal opioid overdoses right now.
Well, thank you. Dan, I just sort of feel, with NAMI, National Association of Mental Illness, I want to give you like the last 15 seconds. If you wanted to tell people out there that are lay people who don't know about this, how they can help, what they can do, what would that be?
It would be to connect with the resources that NAMI has at NAMI.org, or to reach out to us on info@NAMI.org. And also our helpline is at 1-800-950-6264. And also say to ask your leaders in your community about 988. Ask your elected officials, where do they stand on 988? Do they know about 988? We don't see it as the panacea, but we see it as a part of the transformation of mental health care and mental health resources. And I would also say that when you ask about youth, we see the pain and the suffering that many of our youth are dealing with. So we are building out a youth and young adult task force. We also have a very robust ambassador program because, if I see someone who looks like me, I am more interested in hearing what they have to say. So our youth and young adults program is very good. And it will take all of us. And I think that this is a good example of us coming together and building this tapestry of working together.
Well, thank you. Well, we've got Congresswoman Johanna Hayes up next, but I'm going to thank Dan Gillison, the CEO of National Association of Mental Illness, Courtney Hunter, Vice President, State Policy for Shatterproof, David Fiellin, Professor of Medicine and Emergency Medicine and Public Health at the Yale Program in Addiction Medicine, and Jim Carroll, co-founder of DC Consulting and the former director of the Office of National Drug Control Policy. I really appreciate all of you for joining us today. Thank you.